Hello everyone. We will talk today about an important topic, which is descending aortic aneurysm etiology and when to intervene. Here is our agenda for today, and probably by the end of this lecture we will know who is in this picture. The aorta, beside working as a conduit that transmits about 200 million of liters of blood in average lifetime, it acts also as a second pump responsible for perfusion of vital organs during diastole due to its high elasticity. When dealing with aorta, we should deal with it as a whole organ, taking in consideration that 25% of patients with abdominal aneurysm also have thoracic aneurysm, and 85% of femoral aneurysm patient has also abdominal aortic aneurysm. And the aortic aneurysm patient is actually a high cardiovascular risk patient in the term of MI and stroke. He has the 10 years risk of mortality from MI or stroke in this patient is actually 15 times the risk of aorta-related deaths. In terms of definition, the descending aorta starts at the aortic isthmus, just distal to the left subclavian artery, and normally with aging, the aortic diameter increase about 1 millimeter per decade, and the diameter decrease as we go distally. So an aneurysm is defined as a diameter more than 15% of adjacent healthy segment, with a cutoff point 30 millimeter for infra-aortic aneurysm and a higher cutoff point of 40 millimeter for descending thoracic aortic aneurysm. 80% of aortic abdominal aneurysm are infrarenal, mean on the segment below the renal artery. But why? Because the number of medial elastic lamellae forming the medial layer decrease as we go distally in the aortic tree, from a 55 layer in the ascending segment to about half this value, 26, at the aortic bifurcation, and the wall become thinner and weaker as we go distally. So 80% of abdominal aortic aneurysm are infrarenal. Regarding the etiology of thoracic aortic aneurysm, it has a variety of causes, but degenerative cause is the most common one, which shares the same risk factor of atherosclerosis like aging, male gender, smoking, and hypertension. Other causes are hereditary, which divided into two main categories: syndromic like Marfan, Ehlers-Danlos, and non-syndromic thoracic aneurysm and dissection syndrome. But actually hereditary cause predominantly in the aortic root rather than the descending thoracic aorta. Other less common causes are inflammatory causes like Takayasu and joint cell arteritis. Regarding abdominal aneurysm, the atherosclerotic aneurysm is the most common one, with male gender is strong risk factor, fivefold likelihood in comparison to females, and smoking increases the risk sevenfold. Family history is also present in about 20% of cases and increased to about 24% in monozygotic twin, highlighting the importance of genetic background as a potential player in the pathogenesis of aneurysm. At molecular level, the previously mentioned risk factor cause increase hemodynamic stress that lead to expression of genes responsible for proteinase enzymes like metalloproteinase, chiamase, and elastase, that leads to degradation of matrix proteins, lead to mechanical failure of medial elastin and adventitial collagen, and finally aortic dilatation and aneurysm formation. Specific pathophysiology for infrarenal abdominal aneurysm that it lack vasa vasorum, cause as we just mentioned that the lamellae about 26 layers, so it has a thin wall and depend on direct diffusion of nutrients from the lumen through the wall. This supply chain actually interrupted when an atherosclerotic plaque become adherent to the intima, leading to decreased nutrition of the medial layer, medial ischemia, and smooth muscle cell apoptosis, and hence a higher risk of aneurysm in the infrarenal segments. The clinical presentation of aneurysm is actually silent and accidentally finding during imaging done for another cause, or catastrophic presentation with complication like dissection, rupture, or thromboembolism. Less likely to present with pressure symptoms like cough, shortness of breath, hoarseness of voice, or difficulty swallowing for thoracic abdominal aneurysm, or back pain for abdominal 1. Also might present with pulsatile mass below the umbilical level, but need a thin individual to be appreciated. And hence the importance of systematic screening for such silent disease. And actually it is one of the few diseases in the whole medicine where systematic screening shows mortality benefit. And it carries class 1A indication in the ESC guidelines, systematic screening for male above 65 years with curvilinear ultrasound probe, or opportunistic screening during, for example, echocardiography using the echo probe on male above 65 years. Also should be considered in a female smoker or on patient with positive family history. And here is a meta-analysis that shows a significant reduction of aneurysm-related mortality, about 45% reduction in systematic screening using ultrasound in male above 65 years, as shown here. CT aortography is an important investigation, not only for detection of the number of aneurysm, maximum diameter, and potential complication like dissection or Mueller thrombus, but also is important in procedural planning, assessing the landing zone for its diameter, length, and angulation. This is actually important, especially for percutaneous solutions like TVAR or EVAR planning. Not free of common disadvantages like ionizing radiation and contrast, as we all know. Also, the inter and intra-observer variability for CT serial assessment is less than 5 mm, so any change beyond this point above 5 mm on serial CT is considered significant. Another solution to avoid the cumulative radiation and contrast, especially in serial follow-up of young patient, is cardiac MRI, but as a disadvantage, it's not sensitive for calcification and not ideal for stainless steel stent graft. PET scan also might be of help in patients with inflammatory causes like tachycardia or giant cell arteritis, or for detection of some complication related to stent graft like infection. Regarding the natural history of aortic aneurysm, the descending thoracic aneurysm grow faster in comparison to the ascending aorta on a rate of 3 mm per year in comparison to 1 mm per year. Abdominal one even grow faster in up to 6 mm per year. This figure actually doubled in smoking. The rupture is higher in women than in men with similar diameter. For example, a male patient with aneurysm of 5.5 centimeter has similar risk of rupture of a female with a smaller diameter of 4.5 centimeter. And this actually translated into a mortality of 200,000 cases per year worldwide. A basic physics to understand when to intervene for an aortic aneurysm is the famous Laplace law, which states that the wall tension on the, for example, aortic wall is directly proportional to the radius of the lumen and inversely directed to the wall thickness. And as aortic aneurysm grow in diameter, this factor increase, which is the radius, and the thickness become decrease. And so finally the wall tension will markedly increase. And this is a continuous process, as we see here. An aneurysm with such a diameter has a wall tension and risk of rupture double this one and quadruple this diameter. So what is the management? Besides lifestyle modification like avoid competitive sports and counseling before pregnancy in young females, especially in those with collagen disease like Marfan, which is autosomal dominant with high likelihood of transmission up to 50% and a high risk of rupture or complication during pregnancy, especially if the diameter beyond 40 millimeters should be fixed before pregnancy. But actually, this less commonly seen in descending thoracic or abdominal aneurysm, because most causes are degenerative, seen mainly in old age. And medical control of risk factor like hypertension using ARBs or beta blocker by data extrapolated mainly from Marfan syndrome patients. Stop smoking is important because, as we just mentioned, that smoking doubles the risk of aneurysm-related complication, rupture, or dissection. And as we said on the first slide, that aortic aneurysm patient is a cardiovascular disease high-risk patient with high potential risk of 10 years incidence of myocardial infarction and cerebrovascular stroke. So high-intensity statin should be considered, especially on atherosclerotic 1, and low dose of aspirin might be considered, as mentioned in the latest American Heart Association guidelines for aortic aneurysm. And finally, intervention when reaching a certain cutoff point, as we will discuss. So when to intervene and how in thoracic abdominal aneurysm when the potential benefit of intervention outweighs the risk of the procedure itself. This justify the intervention. And when reaching this important equation, as we can appreciate here, a cutoff point 5.5 beyond which the risk of aneurysm related complication becomes striking high. So this cutoff point for intervention is 5.5 centimeter for percutaneous solution like T-bar. A higher cutoff point for surgical intervention, 6 centimeter. And the lower threshold for intervention in collagen disease patient like Marfan or Ehlers-Danlos patient might be considered at 50 millimeter and even 4.5 millimeter. So when to choose open and when to choose TEVAR, we should know that TEVAR has significant lower 30-day mortality in comparison to open surgery. But this benefit actually lost on the long term due to higher rate of re-intervention and stent graft related complication on the long term. So the choice of this modality need multidisciplinary team discussion with expertise in both methods, taking in consideration patient age, life expectancy, and the comorbidities and feasibility of each pathway. So, for example, if we have a young patient, for example, male 40-year-old, and he has a thoracic descending aortic aneurysm, in this patient, the life expectancy is long. So, and he has no comorbidities, so open intervention might be preferred in such profile. On the other hand, if we have a 70-year-old patient and has comorbidities, so TEVAR might be preferred in such patient profile with less life expectancy. And not only the patient, but also anatomical criteria should be fulfilled for percutaneous solution, like landing zone less than 40 millimeter, length more than 20 millimeter. And this also a novel solution, as in about 40% of patients, the graft stent might encroach on the subclavian, so they might opt for transposition of left subclavian or carotid to subclavian bypass to prevent potential subclavian ischemia. And as we said before, the perioperative mortality of surgery is higher in comparison to percutaneous one. It's about 17% in surgery in comparison to almost a third this figure, which is 5.6 in percutaneous intervention. But as we just mentioned, that this benefit lost on the long term due to higher rate of re-intervention and stent graft related complication like endoleaks in TEVAR patient. And regarding abdominal aortic aneurysm, when to intervene, on this figure, the study compare either percutaneous intervention with EVAR or surveillance and conservative management of patient with aneurysm less than 5.5 centimeter in the abdominal segments, and we can appreciate no significant difference below this cutoff point. So we can conserve on a patient with abdominal aortic aneurysm with diameter less than 5.5. On the other hand, the risk of rupture increased significantly beyond these cutoff points and becomes striking high as we reach 6 or 7 centimeter of diameter. So an aneurysm beyond the cutoff point of 5.5, the intervention outweighs the potential risk. And hence the ESC and AHA recommendation for intervention on abdominal aortic aneurysm, the cutoff point 5.5 centimeter or rapid growth more than 10 millimeter per year, and a lower cutoff point of 5 centimeter should be considered in female, as we mentioned before that female has a higher risk of rupture in comparison to males and occur actually in earlier diameters. Again, the choice between open and EVAR need multidisciplinary team discussion, taking into consideration the patient age, life expectancy, comorbidities. In general, EVAR or percutaneous endovascular aortic repair has significantly lower 30-day rate of mortality in comparison to open surgery. But again, this lost during long-term follow-up due to high risk of reintervention and stent graft related endoleaks and complication. And the anatomical criteria should be fulfilled before thinking about EVAR. It is fit for infrarenal aneurysm with adequate landing zone diameter of less than 30 millimeter and length more than 15 millimeter, and lower angulation than 60 degree to avoid endoleaks, no thrombus. And as we said, the procedure mortality is higher in open intervention, 4% in comparison to only 1.3% on percutaneous intervention. Again, it is lost on the long term due to higher rate of reintervention, as clearly seen here on the EVAR-1 trial. At 8 years, there is loss of the mortality, early mortality benefit seen with EVAR in comparison to surgery due to higher reintervention rate. And in a specific subgroup of patients with high comorbidities and not fit for surgery, intervention with EVAR in such high-risk patient didn't actually decrease the all-cause death, only decrease aneurysm-related death, and this is actually expected due to unexpected death related to non-cardiac or non-aneurysm-related causes due to high comorbidities in such patients who are unfit for surgery. So the class of recommendation here is 2B. And after intervention, as we said, the patient has long journey of serial surveillance and follow-up for detection of complications. The most famous complication is endoleaks. That means continuous flow into the aneurysm sac with time. It has 5 types. Type 1, that means the entry point to the aneurysm sac is related to the landing zone, either the proximal or distal landing zone, and this should be fixed with either further dilatation or another stent if detected on the baseline procedure or the follow-up, because it carries poor prognosis. Also, we have type 2 endoleak, which means the aneurysm continue to fill through side branches or collaterals. Type 3, which is mainly due to mechanical disintegration of the graft stent, and this actually need active intervention with another limb to seal this defect, because it also has a poor prognosis. Both type 1 and type 3 has the poorest prognosis. Type 4 is actually caused by the porosity micropores through the graft stent, and this actually sealed with time. And type 5, which is called endotension, that means we have a progressive increase in the diameter of aneurysmal sac with no other obvious cause. The date of or the surveillance schedule usually with CT aortography at 1 month, 6 months, and at 12 months, then on yearly basis. To minimize the risk of repeated exposure to ionizing radiation with CT, abdominal ultrasound surveillance should be considered in patient who has no complication at 12 months follow-up, and only non-contrast CT scan every 5 years might be sufficient, or using less or more safe modality like MRI, especially in young age. Regarding surgery, only more loose follow-up at 5-year interval with either abdominal ultrasound or CT is enough. And regarding surveillance for patient with conservative management, if the aneurysm has a diameter more than 4.5 centimeter in thoracic segment, serial follow-up every 6 months is important for early detection of further aneurysm dilatation and early intervention before complication. And every 1 year for abdominal aneurysm if reaching a diameter above 4.5 centimeter. And finally, we have a more complex subset of thoraco-abdominal aneurysms. That means that thoracic aneurysm extend beyond the diaphragm into the abdominal segments. And we have the modified Crawford classification for such type of aneurysm, with the first three subsets are the more complex, and they carries a very high risk of intervention with mortality more than 10% and incidence of paraplegia very high in comparison to isolated thoracic or isolated abdominal one. And under research, a novel solution which is called fenestrated EVAR for such patient to preserve on the vital branches arising from the segments of aorta. Finally, my take-home message is first, we should deal with aortic aneurysm patient as a high-risk patient with a likelihood of dying from myocardial infarction and stroke 15 times the likelihood of dying from the aneurysm itself. And it is a silent disease, so systematic screening in male above 65 years with abdominal ultrasound is recommended. Control risk factors, taking in consideration that smoking doubles the risk of rupture, and respecting physics and epidemiological data with early intervention as a cutoff point 5.5 centimeter with a lower threshold of intervention, especially in female at 5 centimeter for infra-aortic abdominal aneurysm. And the choice between open or percutaneous solution, taking in consideration the age life expectancy of patient, taking an important point that percutaneous solution has significantly lower 30-day mortality, but on the other hand, they have a high likelihood of reintervention and complication on the long term. And finally, this picture is of Professor Charles Dubost from France, who did the first abdominal aortic aneurysm surgery for a 50-year-old patient presenting with abdominal aneurysm and ischemia related to occlusion of the left common iliac artery. And he performed a homograft between the descending aorta and the right common iliac artery, followed by endarterectomy and reanastomosis of the left common iliac artery. This homograft taken from a cadaver died 3 weeks prior, and here's the final result. And to appreciate that the patient with aortic aneurysm is actually a high cardiovascular risk patient, this patient survived the aortic aneurysm, but he actually died from myocardial infarction 8 years later. And finally, thank you for your attention.